If you're preparing for the CCE exam, this video could save you 6 months of delayed fellowship and paying a second $5,565 exam fee. Everything I'm going to cover is drawn from the specific patterns I've seen coaching over 60 doctors through the CCE, many of them on their second or third attempt. The mistakes that cost marks in the CCE are remarkably consistent. The most common are long, unstructured answers the examiner can't follow, ordering excessive investigations without proper rationalization, and failing to vocalize safety considerations. In most cases, the doctors making these mistakes know the medicine. They just don't present their knowledge in the way the examiners mark. Here's the good news. Every one of these mistakes is avoidable. In this video, I'm going to walk you through the 5 most common failure patterns I see in CCE candidates. Then, we'll look at the preparation strategies that actually work the best and proven exam day techniques that help you perform under pressure. Before we get into failure patterns, it's worth understanding why the CCE trips up so many capable doctors. It tests something fundamentally different from every other exam you've sat. You see, the AKT and KFP are internal exams. You read a stem, weigh up the options, and select the answer. The process happens inside your head. The CCE is the opposite. It's about the external presentation of clinical knowledge. Differentials have to be spoken aloud. Safety netting has to be vocalized with specific, actionable language. And management plans must be structured so the examiner can follow your logic in real time and attribute it to the correct competency domain. The principle I return to again and again when coaching is this: if you didn't say it, you didn't think it. In the CCE, the examiner can only credit what they hear. In other words, reasoning that stays in your head scores 0. This is why knowledgeable and capable doctors fail the CCE. It's not because they lack knowledge. It's because they haven't practiced verbally presenting clinical reasoning under timed, observed conditions, the conditions that the CCE exam involves. And here's why getting it right the first time matters so much. Take a look at this table. After a first failure, the probability of passing the CCE exam drops by nearly 25 percentage points, and it continues to drop with each subsequent attempt. In my experience, this isn't because candidates forget the medicine between attempts. It's because the habits and anxiety that caused the failure compound and become harder to unlearn. The most effective intervention after a failed CCE attempt isn't more study. It's better preparation. Specifically, preparation that targets the verbal performance skills that the exam actually assesses. So with that context, let's get into the 5 failure patterns I see most often and how to avoid each one. Failure pattern 1, presenting answers without structure. Candidates often know the correct answer, but can't communicate it in a way the examiner can follow. Clinical points get buried in rambling, and responses jump between history, investigations, and management without a clear framework. Here's how this looks like in practice. An unstructured answer might jump from mentioning a medication to a differential, back to an investigation, then to a referral. This information is all correct, but it's impossible for the examiner to follow. A structured answer, on the other hand, moves through a consistent sequence. The examiner can track it in real time and attribute it to the correct competency domain. Here's the fix to presenting answers without structure. Before you speak, have a mental framework for every question type. For a management question, I recommend splitting your answer into pharmacological and non-pharmacological management, then working through each systematically. Under pharmacological management, distinguish between symptomatic treatment and disease-modifying treatment. Under non-pharmacological, cover lifestyle factors, referrals, patient education, safety netting, and follow-up. Structured mnemonics like SNAP PW and Recap R can help you cover all non-pharmacological management factors without relying on memory under pressure. You can also use established frameworks like Socrates for history taking, ICE for understanding the patient's perspective, and SPIKES for breaking bad news. These frameworks all give you a consistent structure to fall back on, so you present your clinical reasoning clearly. Failure pattern 2, rambling rather than reasoning. This is related to poor structure, but the underlying problem is different. In most cases, rambling candidates aren't disorganized, they're anxious. They try to cover everything, hoping that volume will compensate for uncertainty. It doesn't. Examiners are trained to identify focused, logical, clinical reasoning. A long answer that touches 12 differentials without prioritizing any of them signals that you can't distinguish the likely from the unlikely. It also makes it very difficult for the examiner to pick up on the key information, especially if you're speaking quickly, which most candidates do under pressure. The fix is twofold. First, slow down and enunciate. Give the examiner time to hear and attribute what you're saying. Second, and this is the most important part, prioritize ruthlessly. If a question asks for differentials, lead with the 2 or 3 most likely given the clinical picture. Explain briefly why each fits, then mention 1 or 2 serious conditions to exclude. That's a complete answer. The instinct is to cover everything, and that is playing it safe. But in the CCE, it achieves the opposite. Failure pattern 3, over-investigation. Ordering every available test is one of the most consistent failure patterns I see. When asked what investigations they'd order, candidates often default to a comprehensive list rather than a targeted selection appropriate to the specific patient. The CCE rewards clinical prioritization. The question isn't what tests exist for this presentation, it's what test does this patient need given their history, risk factors, and the clinical picture in front of you. An experienced GP doesn't order everything. They order what's evidence-based and what will change their management. That's the standard the examiner is scoring against. Here's the fix. For every investigation you mention, ask yourself, will the result change what I do next? If the answer is no, don't order it. Also, be sure to practice articulating why you're selecting each test. For example, I would order iron studies because I need to rule out inflammatory bowel disease given the patient's history of abdominal pain. That reasoning is what earns marks, not the length of the list. Failure pattern 4, missing red flags and patient safety considerations. One of the most heavily penalized patterns in the CCE is failing to demonstrate that you're a safe clinician. And this doesn't usually mean missing something obvious. It means not considering the things a careful GP would always rule out, even when unlikely. For example, a patient presenting with chest pain will most likely have something benign, but it's still essential to vocalize that you'd want to exclude an MI or a PE. Not because you think that's the diagnosis, but because a safe GP always considers it, even if it's a young, healthy, fit male. The same principle applies to prescribing, let's say, medication without checking for interactions, not conducting a suicide risk assessment in mental health presentation, or failing to address consent, cultural safety, or medico-legal considerations. In short, if there's a safety consideration that exists in the case and you didn't name it, it's really hard for the examiner to give you credit for recognizing it and for thinking that you are a safe candidate. This is the classic, if you didn't say it, you didn't think it principle. And this is where it matters the most. Here's the fix. Build a safety screen into every station. Before you pursue the presenting complaint in depth, actively ask yourself 4 things. 1, what is a serious diagnosis I need to exclude here, even if it is extremely unlikely? 2, are there any specific prescribing risks at play here? 3, what about a mandatory reporting obligation? And 4, is there a cultural safety consideration? These don't need lengthy discussion. They just need to be named. Vocalizing them takes seconds, and it's often the difference between passing and failing a station. Okay, let's move on to failure pattern 5, missing cultural, ethical, and medico-legal dimensions. The RACGP increasingly tests cultural safety, Aboriginal and Torres Strait Islander health considerations, ethical reasoning, and medico-legal awareness. These are areas where candidates with strong clinical knowledge routinely lose marks, not because they lack the instinct, but because they haven't practiced applying this reasoning in a structured, vocalized format. Here's what this looks like in practice. A candidate manages a clinical presentation competently, but doesn't consider the medico-legal implications of a mandatory reporting scenario, or doesn't address the cultural safety dimension of an Aboriginal or Torres Strait Islander patient. That candidate is leaving marks on the table in domains that are actually straightforward to prepare for. To fix this, for each case you practice, actively ask yourself whether there's a cultural safety consideration, any ethical elements to the case, or any medico-legal obligations that are at play. These are core competency domains the RACGP is explicitly testing. Practice being cognizant and identifying them in every case you work through, even when they're not the primary focus. So you're building the habits for identifying them automatically by exam day. So those are the 5 most common patterns that cost marks in the CCE exam. Now let's talk about how to structure your preparation so you don't fall into them. The single biggest shift that candidates need to make when moving from the written exams to the CCE is stop studying silently. The CCE doesn't test what you can recognize on a page. It tests what you can say out loud, in sequence, under time to pressure. That's a distinct skill, and it requires its own focused preparation. Here's a simple self-test you can do right now. Close whatever you're studying, turn to the person next to you or an empty chair if you're alone, and explain the topic as if you were presenting to a junior medical student. If you can't do that fluently, you haven't learnt it at the level the CCE requires. And that's regardless of how well you understood it when you were reading it. Now, an important note here. This doesn't mean you should memorize scripts. Scripted answers are actually frowned upon by the examiners because they can sound robotic and they fail to adapt when the patient says something unexpected. What you want instead is a framework, a consistent structure for organizing your response that you can populate with case-specific content in real time. The structure stays the same, but the details change with each patient. Next, structure your study around your energy. Not all study hours are equal. For most candidates, a focused hour in the morning is worth more than 2 exhausted hours at night. But it's not realistic to only study in the morning. So here's how I recommend thinking about it. When your energy is high, that's when you tackle the difficult cognitive tasks. Content you've forgotten since the AKT and KFP, new clinical topics, building understanding from scratch. This is what takes the most cognitive effort. So do it when you're the sharpest and the most alert. When your energy is medium, that's for active practice. Working through cases, verbalizing answers out loud, practicing clinical examinations, and reviewing flashcards. With this type of practice, you're applying knowledge rather than building it. Your energy is low, that's for passive review. Reading through familiar notes, revising material you've already consolidated, reviewing visual content like derm images, ECGs, and X-rays. This keeps knowledge warm without demanding deep concentration. This approach is particularly relevant if you're balancing full-time clinical work with exam prep. If you only have 60 to 90 minutes a day, allocating that time according to your energy level makes a measurable difference over several months. My next tip for structuring your CCE exam prep is to build familiarity through volume and variety. The CCE can test a broad range of clinical knowledge across 12 competency domains. You can't predict which presentations will come up, but you can make sure that nothing feels completely unfamiliar. And the way to do that is work through as many cases as possible across the widest breadth of topics you can. This is especially important for presentations you're not confident in. The temptation is to avoid those cases and focus on your strengths. But the opposite approach is what builds exam readiness. When you practice structuring an answer on a topic you are unsure about multiple times, it becomes second nature to do the same thing under pressure on exam day, even if the specific presentation is one you didn't expect. Expose yourself to everything, common presentations and uncommon ones. pediatrics, mental health, medico-legal scenarios, cultural safety cases. The goal isn't to memorize all of the answers. It's more so to build the confidence that no matter what comes up, you have a structured approach that works. Next, use real patients as study triggers. The conventional advice is to see more patients to prepare for the CCE. That's not wrong, but it's incomplete. Seeing patients passively without deliberately connecting the encounter to your study doesn't build the structural clinical reasoning the exam requires. A more effective approach is this. When you see a patient with a presentation that would make a good case, for example, chest pain, abdominal pain, urinary incontinence, treat it like a mock station. Take a structured history the way you would in the real CCE exam. Examine the patient from top to toe thoroughly. Explain your differentials, diagnosis, and management out loud, following a clear framework. Obviously, this won't work for every patient. A MedCert request or a straightforward cold isn't going to really be the best preparation. But for presentations with real clinical depth, like, "Doc, I have abdominal pain," use them as live practice. Also, when you encounter a presentation you're not fully confident managing, use that as your study trigger for the evening. Research the topic, work through the differentials, refresh yourself on the guidelines. If appropriate, get the patient in for a further review and use that follow-up consultation as an opportunity to reconsolidate what you've learned by applying it in a clinical setting. That way, your clinical work becomes part of your study system, not separate from it, and you're fully utilizing your 8 to 4 in the clinic. Now let's talk about structuring your preparation overall. One principle before the specifics. It is vital to start with the right foundations. How you use your reading time, how you structure your answers, how you approach each case type. These are habits that form early in your preparation, and it's far easier to build them correctly from day one than to unlearn bad habits after a failed attempt. With that in mind, here's the approach I recommend. Start with cases under exam conditions. The foundation of CC prep is practicing with realistic cases. Cases that are too short, too simple, or formatted differently from the actual exam create false confidence. You need cases that replicate the complexity, timing, and structure of the real CCE so that exam day feels familiar, not foreign. Practice under timed conditions from the beginning. Set a timer for 20 minutes per station, 5 minutes reading time, and 15 minutes of actual station time. Record yourself if possible, or work with a study partner who can use role-play scripts to simulate the patient encounters. The goal here isn't to get the right answer. It's to practice delivering a structured response within the time constraints. That's the skill the CCE is actually testing. The next tip is to address knowledge gaps with targeted review. Your cases will reveal gaps in your knowledge. And when they do, address them efficiently rather than restudying everything from scratch. It's far more effective to use concise clinical topic guides that cover differentials, red flags, examination, investigation, management for specific presentations, rather than rereading entire textbook chapters, the entire of ETG, or up to date on that particular topic. Focus your review on what your practice cases have shown where you have forgotten potential knowledge from AKT or KFP instead of covering every single topic all over again. Next, reinforce with active recall. There's typically a 6-month gap between the AKT KFP and the CCE. That's 6 months in which everything you consolidated for the AKT and KFP is gradually leaking away. Think of your memory as an inflatable pool with a small hole in it. Every time you study, you're filling the pool. But if you stop, the water level will drop quickly. Doing constant repetition with flashcards tops it back up. But the real goal is consolidation or patching that hole so that the knowledge stays. That's why spaced repetition works. You don't just see the material again, you retrieve it at increasing intervals so that the memory moves more into long-term storage. For CC preparation specifically, the most effective approach is to build your preparation around verbal recall. Practice how you would say the answer to an examiner, how you recognize it on a page. That's the difference between AKT level knowledge and CCE level performance. And finally, book a mock exam. This is one preparation step that consistently separates candidates who pass from candidates who don't. they undertake a full mock exam under realistic conditions with live examiner feedback. You see, self-study reveals knowledge gaps, but a mock exam reveals performance gaps. The habits, timing, errors, and structural weaknesses that only become visible when someone is watching and scoring. A mock exam is particularly valuable for identifying your potential CCE failure patterns. You may not realize, or your study partner may not have told you, that you're over-rambling, you're over-investigating, there's a lot of safety concerns that you've missed, until an experienced examiner tells you directly. So those are the preparation strategies for the CCE exam. Now let's talk about what to do on the day itself. Technique number 1, use your reading time wisely. You get 5 minutes of reading time before each station. Most candidates just use it to read the case, but that's not enough. You should be making structured notes during that time and fully utilizing that 5 minutes. I would be writing down things like history presenting complaint, problem list, key differentials, important investigation and examination findings, management in terms of non-farm and farm, and I would definitely highlight any red flags or urgent referrals that might be required. This already gives you a structured roadmap before the station even starts. And so when the station does start, you're not figuring out where to begin, you already know. That 5 minutes of preparation is crucial to setting up the next 15 minutes in the station. Technique number 2, pause before you speak. When the examiner asks a question, resist the urge to start talking immediately. In my exam, said something along the lines of, please give me a moment to collect my thoughts. I then talk 5 to 10 seconds to take a deep breath and organize my response. Then I would speak. From the first sentence, I was quite composed with the way that I would speak. And even though it sounds like a small technique, I found that it made a significant difference to coming across as confident to the examiner from the very get-go and leaving a good first impression. The third technique is, if you get lost in a patient sim, summarize. Because there will be moments where you're midway through a consultation and you're not sure what to say next. Instead of just blanking out and going silent and stumbling and mumbling, I usually say something along the lines of, so Susan, just to make sure I've got this right, you said that you've been experiencing abdominal pain, it's been lasting for 7 days, the pain is central, it's radiating to your groin, and you've been vomiting. Would you be able to confirm if I've got that correct? This does a couple of things. First, it buys you time to collect your thoughts. It demonstrates to the patient that you're actively listening, which is one of the competency domains the examiner is looking for. It also reveals where the consultation needs to go next when you catch up to where you are in the consult. The fourth technique is ask ICE early. In the first few minutes of a patient's sim, ask about the patient's ideas, concerns, and expectations. This tells you where the consultation needs to go, and it prevents you from spending 10 minutes going down a clinical rabbit hole that the patient was never worried about. I actually spoke to a candidate after exam that they only found out with about, I think, 2 minutes to go in the exam, that the patient had several kilos of unexplained weight loss and they were concerned about cancer. And if they had asked those questions early on in the station, I'm quite confident it would have come out a lot earlier and they would have had a lot more time to focus on digging into that. Everything I've covered in this video reflects how I approach the CC prep with candidates I work through at Fellow Academy. If you found this useful, I would encourage you to try our free trial. It has 8 CCE cases, which are written to the exact standard of our full case bank. So you can see exactly how we structure our exam preparation. I'll also leave a link below to the written version of this guide on our website, along with a few other useful resources that we discussed. Thanks for watching and good luck with your CCE preparation.